I was charged to present a live stroke case of a tandem occlusion. This is from several years ago. My approach has changed a little bit. Also, I know that there are many ways to treat a tandem occlusion. Our preference is to not stent acutely and to open the intracranial circulation first. Increasingly, we're seeing more and more tandem cases that we were previously excluding. So about 20–25% of our cases have some form of tandem occlusion. This is a 67-year-old patient, hypertensive, who became acutely unresponsive, transferred to our hospital about 3.5 hours after witness onset and had received intravenous TPA. This is the CT scan on arrival, an old area of encephalomalacia in the left anterior frontal lobe. Otherwise good aspects, no change on CT. CT angiogram shows a left ICA terminus occlusion and a stenosis at the left internal carotid artery origin. Perfusion imaging showed large perfusion deficit on the left side with favorable morphology. This is also generated from the CT angiogram, and we see slow flow into the intracranial internal carotid artery. So our approach, given that stenosis at the left ICA in this case, I think we were pretty sure that up front we will have to go in and open that occlusion in order to gain access to the intracranial circulation. Our preferred option or modality is just primary angioplasty. In the past, we were somewhat timid and using 2mm, 3mm balloons. Now we do maximum angioplasty with at least a 5mm balloon, and about, I would say, estimating about half of the times, or a little more than half of the times, that is all we do and don't have to do an acute stent placement. So there's the stenosis at the origin, slow intracranial flow up to the ICA terminus. This is a balloon guide catheter. Today, I would not use a balloon guide catheter for something like this. I would use an 8 French long sheath, either the Neuron Max Infinity or of some other variety. This is, I think, from 4 or 5 years ago. And so we had a balloon guide catheter. We cross the lesion and do a angioplasty with a 5mm balloon. We had to do this twice. There was significant recoil. On the CT scan, we did not see a heavily calcified plaque, so I was not expecting that degree of recoil. The balloon inflated pretty well. And post-inflation, we see some improvement of flow. But when we do the angiogram, there is significant residual stenosis, very irregular looking plaque. I did not want to go more on the balloon size, so we chose to stent the patient. The patient had received intravenous TPA. We administered clopidogrel and aspirin, and we administered that when we had placed the balloon guide catheter prior to the angioplasty. This is a 8/6 tapered protégé stent, 40mm. We deploy the stent, do an angiogram, which shows recanalization of the clot, recanalization at the ICA origin. There is a persistent ICA terminus occlusion. From this point on, we use an intermediate catheter, microcatheter wire combination with the plan of using a stent retriever. Today, I would primarily use aspiration with a large bore catheter, such as Jet 7, primarily, or Sophia Plus. So we take the intermediate coaxial XT27 catheter combination over the synchro. The CAT6 is positioned just proximal to the siphon. The microcatheter is beyond the occlusion. We do a very gentle injection to make sure where we are landing our device. This is a Trevo 6 ProView 6x25. And deployed in a standard push-pull fashion, making sure that we come proximal enough to the ICA terminus so that the device is centered over the meat of the thrombus. We do a run which does show some recanalization through the main M1 segment. And we retrieve the stent retriever, advance the intermediate catheter close to the terminus. In this case, I remove the stent retriever through the intermediate catheter because of the stent and not wanting to recross the stent multiple times. After the first pass, we have recanalization of the main stem, but there is occlusion at the superior division. So keeping the intermediate catheter that was left in place, we go back up. The wire first goes in the inferior division, withdraw it, make a J and go into the superior division, and use a smaller 4 millimeter Trevo. And do a second pass in a similar fashion. Only aspiration was performed through the intermediate catheter, and that was manual aspiration. We see it's recanalized, but there's still much distal occlusion, which we left alone given the fact that the patient already had a large area of tissue loss corresponding to that occlusion. And this is the post one-day CT with some petechial hemorrhagic staining, some deep gray infarct. Patient did have neurological improvement of NH stroke scale. Initially was 18, went down to 6. And we kept him on aspirin Plavix. So the questions, I guess, here in the face of IVTPA, what people's preference are in terms of acute antiplatelet medication, and what is the timing. I know there are many approaches. This is a very sophisticated audience. I don't think there is one dogmatic approach that fits everything. Our preference at our center is to open the intracranial circulation. He had an ICA terminus occlusion. There have been cases where we have opened the middle cerebral artery and are unable to open the carotid, but check the contralateral circulation, and if there's good flow, we even stop, maintaining medical therapy and blood pressure control. I know I'm over my time, so I'll stop.